Revision. It's one of those things, isn't it? Especially for big exams like the MSRA, the amount of information can just feel overwhelming.
Absolutely. Like trying to drink from a fire hose sometimes.
Yeah.
And the real trick is knowing what's actually, high yield.
Exactly. What do you really need to know? And that's what this deep dive is all about. We're using your revision notes on bulimia nervosa.
Right.
And our job is basically to sift through them, pull out the absolute essentials, and make it stick for your revision.
We'll cover it all, definition right through to complications, using those notes as our map.
Okay, let's jump in. Definition. What is bulimia nervosa, according to the notes?
Well, fundamentally, it's defined as an eating disorder. The core of it is these recurrent episodes of binge eating.
Binge eating meaning a large amount of food.
Yes, a significantly large amount, and crucially, feeling a lack of control while eating it.
Got it. And that's followed by compensatory behaviors, right? To try and prevent weight gain.
Precisely. And your notes list the common ones. Self-induced vomiting, maybe excessive exercise, fasting, or misusing things like laxatives or diuretics.
And underlying all that is this distorted body image and intense fear of getting fat.
Yeah, that fear is a really powerful driver in this cycle.
So what causes it? Etiology. The notes say the exact cause isn't known.
That's right. It's complex. It's generally seen as a mix of things interacting.
Like genetics, psychological factors, environment.
Exactly. A combination. And feeding into that, you've got things mentioned elsewhere in the notes like sociocultural pressures, the whole thinness ideal.
Media influence, yeah.
Family history of eating disorders or other mental health stuff, and certain personality traits too, like perfectionism, maybe low self-esteem. It's rarely just one factor.
Which leads us neatly into the risk factors. Your notes have quite a list here.
They do. Being female is a significant one, though we should definitely say males get it too.
Right.
And age-wise, it often starts in adolescence or early adulthood. Say 15 to 25 is the typical window.
Family history comes up again here. Eating disorders, mental health conditions.
Yeah, it reinforces that idea of predisposition. Then there are those sociocultural factors again, the pressure to be thin.
And personal history seems important, like previous dieting, body image issues.
Very much so. Negative body image, weight concerns. Perfectionism is listed again as a risk factor. Also, a history of trauma or abuse, significant life stress.
The notes also mention things like parental or childhood obesity.
Yes, and family dieting habits, parental psychiatric issues, or substance misuse. Even early menarche is listed.
And those pre-existing traits like anxiety and low self-esteem.
It really paints a picture, doesn't it? A lot of it seems to circle back to pressure, self-image, and maybe a background of related challenges personally or in the family.
It seems like a good summary. It's like a buildup of vulnerability.
Exactly.
Okay, pathophysiology. How does this actually work inside?
Biologically.
Psychologically.
Well, the notes describe it as these complex interactions. But the core psychological driver seems to be that distorted body image and the intense fear of weight gain.
That's what fuels the binging and purging.
Pretty much, yes.
Yeah.
That distress drives the cycle. And then biologically, there's mention of neurotransmitter dysregulation, serotonin specifically.
Ah, okay. Serotonin affects mood, appetite.
Impulse control, too. All relevant here. The notes also point to disruptions in the brain systems that manage appetite, impulses, and emotions. It becomes a kind of feedback loop.
Makes sense. So differential diagnosis. If someone comes in with these symptoms, what else could be going on? This is crucial.
Absolutely critical for correct management. First off, you need to differentiate it from anorexia nervosa.
Key difference being the weight.
Generally, yes. People with bulimia are typically at or above a normal weight, BMI over 17.5 usually, whereas in anorexia, they're underweight.
Yeah.
That's a major point in the notes.
Okay, what else?
Binge eating disorder. That's got the recurrent binges, the loss of control, but without the regular compensatory behaviors like purging.
Just the binging part.
Right. Then there's the catch-all, other specified feeding or eating disorders category for presentations that don't quite fit the main boxes.
And medical causes.
Definitely need to rule those out. Things like GI problems causing vomiting, endocrine issues affecting weight, even substance abuse can mimic some symptoms.
Good points. Let's talk numbers epidemiology. How common is bulimia nervosa?
The notes give figures around 1–2% prevalence in females, maybe 0.1% in males generally. Worldwide, it might be a bit higher, up to 3% in females.
And that onset age is key for revision 15 to 25, median around 20.
Yes, adolescence and early adulthood is the main time frame. The gender ratio is pretty stark, too, about 3 females to every 1 male.
Does it affect certain groups more?
It cuts across all socioeconomic groups, but it does seem more common in Western societies.
And here's a really striking point from your notes. Many people with bulimia don't actually seek treatment.
Yeah, that's huge. It speaks to the stigma, the secrecy that often surrounds it. It makes tackling it a real challenge.
So clinical features, what does it actually look like when you encounter someone with bulimia?
Well, you start with those core characteristics we mentioned. The recurrent binge eating, that loss of control, followed by the inappropriate compensatory stuff, vomiting, laxatives, excessive exercise, fasting. You're looking for that pattern.
And psychologically.
A major preoccupation with body weight and shape. That intense fear of gaining weight, often tied to a distorted body image. They might see themselves as much larger than they are.
You often see mood issues too, right? Anxiety, depression.
Very common. Mood swings, definitely. Sometimes rigid behaviors around food and eating, which can lead to them becoming quite isolated. Low self-esteem is typical, and sadly, there's a risk of self-harm.
And comorbidities are common, like depression or substance abuse alongside it.
Frequently, yes. It's important to screen for those.
Okay, what about physical signs? Things you might pick up on history or exam. The notes stress that weight is often normal or above normal.
That's a critical point again, differentiated from anorexia. Many physical signs relate directly to the purging. For example, dental erosion. The acid from vomiting damages tooth enamel.
You might also see swollen salivary glands, carotid hypertrophy.
Yes, exactly. That's from the repeated vomiting stimulating the glands. And Russell sign calluses or scars on the back of the knuckles.
Inducing vomiting.
Right. Edema or swelling can also occur, maybe from laxative or diuretic misuse.
And GI symptoms.
Oh yeah, bloating, heartburn, abdominal pain, reflux are common complaints. In rare severe cases, there's even a risk of the stomach rupturing.
Scary. And cardiac risks.
A big concern. Arrhythmias, mainly due to electrolyte imbalances from purging. Hormonal changes to irregular periods, or even amenorrhea, loss of periods.
Your notes also lay out the DSM-5 criteria, which basically summarize this. Binging and compensatory behaviors at least once a week for 3 months.
Yes, that frequency and duration are key. Plus, the self-evaluation being heavily tied to body shape and weight. And confirming it's not just happening during episodes of anorexia nervosa.
Right. Okay, investigations. How do we confirm this and check for problems? The notes are clear. Diagnosis is mainly clinical.
Exactly. It hinges on that thorough psychiatric assessment, taking a detailed history, understanding the behaviors, the thoughts, the feelings. There's no single lab test that says, yes, this is bulimia.
So the medical tests are more about checking overall health and looking for complications.
Precisely that. Screening for the physical consequences and ruling out other medical causes.
What are the key tests listed in your notes?
Okay, so a full blood count. Definitely electrolytes, potassium, sodium, chloride are crucial. Bicarbonate levels too. Liver function tests, magnesium, phosphorus, B12, folate, iron studies like ferritin, urinalysis, and a pregnancy test.
And the main reason for these is to spot the fallout from purging. Electrolyte issues, kidney function.
Exactly. Especially potassium levels. Hypokalemia is a major risk. Kidney function can be affected too. Checking nutritional status.
And an ECG is standard.
Usually, yes, because those electrolyte shifts, particularly low potassium, can cause serious heart rhythm problems. So you need to check the cardiac status for safety.
The notes also mention an optional DXA scan for bone density.
Correct. That's considered if bone loss is suspected, maybe if periods have been irregular or stopped, pointing towards potential osteoporosis.
So the big takeaway from investigations is monitoring those renal and electrolyte issues, dehydration, low potassium, low chloride, metabolic alkalosis. Those are really high-yield points.
Absolutely. Managing those potential electrolyte disturbances is paramount from a medical safety perspective.
Okay, so management. Diagnosis made, what happens next? Immediate referral to specialist care.
That's the recommendation, yes. Get them to an eating disorder service. The approach is generally multidisciplinary.
Combining psychotherapy, nutritional support, sometimes medication.
Right. And the main psychological therapy, the first-line treatment mentioned, is cognitive behavioral therapy, specifically adapted for eating disorders, CBT-ED, because it directly targets the thoughts and behaviors driving the binge-purge cycle. Nutritional counseling with a dietitian is also core, helping to restore regular, healthy eating patterns. Interpersonal psychotherapy, IPT, is another option noted for reducing binges.
What about medications, SSRIs?
Yes, SSRIs like fluoxetine are mentioned as potentially helpful, and this is crucial alongside therapy and nutritional support, not usually as the sole treatment. Sertraline might be used if fluoxetine isn't tolerated.
And the guidelines reinforce that. Specialist referral, outpatient focus mainly, CBT, first line for adults.
Yes, and for younger people under 18, family therapy or individual CBT/ED is often recommended. The notes also acknowledge the evidence base isn't perfect, so treatment needs tailoring.
And general medical management runs alongside, monitoring fluids, electrolytes, dental checks.
Absolutely. Regular dental reviews are important. If laxatives are being misused, they need to be reduced gradually, screening for osteoporosis. And careful management, if the person also has diabetes, that needs close collaboration.
What about the prognosis? Is recovery likely?
The notes actually offer a relatively positive outlook. With proper treatment, remission is possible, well-being can definitely improve.
But it's not always straightforward. Relapses can happen.
That's the reality. Recovery can be a long road and setbacks are common. But early intervention really helps. The notes mention up to 80% can achieve full recovery with treatment.
That's encouraging. And compared to anorexia,
Generally, the prognosis for bulimia is better. Recovery rates are higher and mortality rates are lower than in anorexia nervosa. That comparison is often tested.
okay, finally, complications. What are the serious risks?
Medically, the most acute risks often relate to purging. Those severe electrolyte imbalances, especially hypokalemia leading to cardiac arrhythmias, are probably top of the list. Dehydration, too.
And the things we saw as physical signs can become chronic complications.
Exactly. Chronic dental problems, ongoing GI issues like reflux, esophagitis, and although rare, those catastrophic events like gastric rupture or esophageal tears are potential complications.
Yeah.
Malnutrition and osteoporosis over time.
Hormonal issues, kidney problems like pseudo-Bartter syndrome, cardiovascular complications, and specific risks for diabetics.
Yes. And then there are the psychological and social complications. High rates of depression, anxiety, increased risk of self-harm or suicide. Substance abuse often goes hand in hand. Relationships and daily functioning can be severely impacted.
And the notes mention some might eventually develop anorexia nervosa.
Yes, that's a possible progression for some.
Yeah.
It really underlines the severity and the broad impact this condition can have.
Right. We've really gone through the key points from your notes there: definition, causes, risks, features, diagnosis, management, prognosis, complications.
Yeah, hopefully breaking it down like that, hitting the high yield points, the difference from anorexia, the electrolytes, the role of CBT helps cement it for your revision.
Absolutely. And thinking about that point that so many don't seek treatment despite these serious potential complications, it really makes you think, doesn't it, about the need for awareness and accessible support.
It really does. It highlights a major gap and the importance of destigmatization and early recognition.
Well, if this deep dive has been useful for your MSRA prep, remember there's more help available. Do check out pastthemsra.com and freemsra.com for other revision resources.